beginning. I'm going to get started. Okay. Good morning, everybody. How are you feeling? 7:45 a.m. Saturday morning. Love it. Look at the keeners. Yes. Love it. Wonderful. Welcome, everybody, to this special session. We are so honored and privileged to welcome you to this special session of CAHR called Women with HIV Matter, exploring models of women-centered HIV care in Canada. My name is Angela Kaida. I am with the Faculty of Health Sciences at Simon Fraser University and honored to be one of the PIs of the Chivos study. And before we get started with today's packed and really fascinating agenda, I'd just like to ask my friend, colleague, Claudette Cardinal, to welcome us and acknowledge the territories on which we've gathered.
Good morning. Tansei. Hello. My name is Claudette Cardinal. I'm from the CAHR2018 Nation, that's in Alberta. Don't throw anything at me. I support the pipeline. That's my disclaimer, my disclosure. This morning I just want to welcome you all to this lovely territory. I've been a visitor. I think I'm now a resident. BC is my home. I've been here 20-something years. And I just want to welcome you all to this important work that we're doing on the unceded territories of the Coast Salish peoples, the Musqueam, the Tsleil-Waututh, and the Squamish. And I would just like to honor and salute, and if you'd please rise, and we're going to salute, and in your own mind, have a little prayer for each of the directions. And while you're doing that prayer, keep in mind the people that you've lost or worked with in this great work, and honor them also when we salute the directions. So we'll honor and face the east. And to the south. And to the west. To the north. Hi, thank you.
Oh, but great way to start. Thank you so much, Claudette. So many of you in this room are well aware that women living with HIV now comprise a quarter of all people living with HIV in Canada. And that proportion has more than doubled since earlier days of this epidemic. And so models of women-centered HIV care in Canada also need to be adapted to provide services for women. And part of what we're here to talk about today is what those principles need to be and what is it about caring for women living with HIV that is so different and so important. So I would also like to welcome my co-moderator, Dr. Kate Shannon, to get us started with today's program. Great, so good morning everyone, and thank you everyone for joining us, especially so early. I really want to acknowledge Dr. Mary Kessler from Oaktree and BC Women's, who really was the brainchild behind putting this session together. And what we're hoping you'll hear in this fairly jam-packed session, because we have quite a few speakers, is to hear first from the Chivos group about what women in their research have said they envision women-centered care. And then we're going to move to two sort of examples of women-centered care in practice. So you'll hear from Shauna Project and then the Oaktree Clinic to talk about what women-centered care can look like in different settings on the ground. And then we hope we'll have a little time at the end for discussion to kind of bring that back together for everyone. So I'm going to turn it back to Dr. Kaida to do an introduction for the first session. Just a little keep you animated back and forth. So welcome. So it's my pleasure to welcome three of my Chivos colleagues from across Canada, Wangari Thoreau, Valerie Nicholson, and Mina Kazemi, who will be sharing, as Kate mentioned, some of the research of what women living with HIV have envisioned for women-centered HIV care, and the research and the work that has been underway in Chivos to develop a model. Welcome.
So anyway, I don't want my 5 minutes to start before I can see the slides there. But thank you very much for coming early in the morning like this. If I sound incoherent, blame the early hour of the morning. My name is Wangari Tharau, and I am the Director of Research at Women's Health in Women's Hands, a community health center for racialized women in Toronto. And the three of us are presenting on behalf of the Chivos team, myself, Mina, and Val. Chivos comprises of women living with HIV, service providers, researchers, decision makers, and community members who've come together and worked together since 2010 to actually translate an ideal vision of women-centered HIV care that we had always envisioned we would like to see, and translating into reality in 2018. So that has been a work in progress for many years. I switched it off. Oh, there. So, and I would like to start the presentation on behalf of Chivos by acknowledging the ancestral, traditional, and unceded indigenous territories of Coast Salish people, and in particular, the Musqueam Nation, Tselil, Waututh Nation, Squamish Nation, on whose territory we are privileged to gather today, recognizing that we are all visitors in this land. I hope I don't switch it off again. Women with HIV experience vast social inequities and poorer health outcomes than men with HIV. They have unique social and health concerns requiring complex care. For their medical care, HIV, comorbidities, and issues of aging have to be managed. They also have health issues that have to be taken into consideration, such as sexual health and reproductive health issues. And very often, they have important social needs to be addressed, such as housing, food security, isolation, and so many others. The Canadian HIV Women's Sexual Reproductive Health Cohort Study, Chivos, is the largest community-based cohort of women living with HIV, including trans women in Canada. We have enrolled 1,400 plus women living with HIV from 3 Canadian cities, BC, Ontario, and Quebec, with 18-month follow-up visit. Grounded in principles of critical feminist theory and community-based research, Chivos involves women living with HIV, allied clinicians, researchers, and community members as core partners throughout all stages of the research. Developing a women-centered HIV care model has been a progressive journey, and we have utilized change management theories, our methods, where we have defined the problem, conducted a literature review, and we held qualitative focus groups, 11 focus groups with 77 women in Ontario, Quebec, and BC. We also analyzed quantitative baseline survey data from the 1,400 plus women in the cohort. We use this data to actually develop a women-centered HIV care model, which we have actually gone around and consulted with stakeholders for them to provide input and for them to help provide input into the model, and that's the model we're going to be sharing with you today. And the next part of the presentation is going to be done by Valerie.
Here's a copy of the literature review that we published in 2017. Vision of women-centered care. As a patient, she said, I went to see a gynecologist and he didn't know about HIV. And I was trying to explain to him where I was, you know, my CD4 count, and I was educating my doctor. When the woman was educating the doctor, she wanted to be seen as a patient, not an educator. There is time to educate and there's time to care. As a person, he doesn't just check with your health. He was interested in all those aspects that make you a whole person. You weren't just a chart with a bunch of numbers. We want to be seen as a person, not a bunch of numbers on a chart. As a woman, it's been 3.5 years that I haven't managed to get an appointment. Can you imagine? I'm no longer pregnant, but I'm still living with HIV. I need follow-up. I need a pap test. From a focus group in Quebec, some following statements. She was followed at a specialist clinic during her pregnancy, but after she gave birth, all those specialized care and support fell away. She literally could not be followed for care at the clinic. Women's health care is head to toe. It's not just our uteruses. This also emphasizes the need for coordinated care from specialists to generalists to make sure women's needs are taken care of along their whole life course, not just one moment or a moment in time. As a woman living with HIV, I think everything is working well, and then we go to an HIV specialist clinics. They know us and they're very friendly. However, when we go back to other clinics, when we're asked for our HIV status, they discriminate against us. As a woman living with HIV, see me as a woman, as a person, not as your patient. HIV is just a symptom for me. As a woman living with HIV, one had distinct needs that are specific of being women and living with HIV. These are not the same as other women living with other chronic diseases, for instance. And I'm going to turn it over to Mina.
Okay. So the next step in developing the model of care was analyzing quantitative baseline survey data from 1,422 Chivos participants. The Chivos survey is cis and transgender inclusive. Women in Chivos were ethnically diverse. They have high levels of education, yet low income. Overwhelmingly, 80% of women in Chivos experience violence in adulthood, and 44% experience sexual violence. 48.6% of women in Chivos reported depressive symptoms. 10% of participants never had a pap test in 5 years. HIV care was revealed to be excellent. 96% were retained in HIV care, and 88% initiated on CART. So the conclusions from the Chivos analyses: the experience of violence is central for women living with HIV. HIV care is relatively good, but there was poor women's health. Focus groups, women had poor mental health and potentially poor mental health care, and focus groups stressed the gravity of structural barriers and the necessity of peer support. So we gathered feedback from community members, researchers, clinicians, and other stakeholders, and we developed our model. And I would like to present to you the women-centered HIV care model from Chivos. The model is in the shape of a house to represent safety and comfort. Trauma and violence-aware care is the foundation to acknowledge the alarming high rates of violence and intersecting oppressions women face. Person-centered care with attention to social determinants of health and family is on the first floor. The second floor contains 3 rooms. Women's health
including sexual and reproductive health, mental health, including addiction care, is integrated with competent HIV care. Peer support, leadership, and capacity building are integral to women-centered HIV care and make up the roof. A woman is present inside the house and may be supported by peers to enter the house. The woman is the most essential component of the model and emphasizes the shared care decision-making principle of person-centered care. The women are holding up the glowing piece about peer support. And importantly, the model is meant to be provided to all women in all their diversity, including, for example, cis, trans, two-spirited, and gender non-binary women. And finally, this woman can be of all different ages, as all components of the women-centered HIV care must address her needs across the life course.
Thank you. I would like to acknowledge, and all of us at Chivos, all the women living with HIV who participated in our Chivos study, my fellow peer research associates, and all our funders and our supporters. But remember, all these women have voices. We remember the 57 women living with HIV who have participated in our Chivos study in Canada who have passed away. And please remember and keep their voices alive. Thank you.
Great. Many thanks, Chivos, for a really great presentation and setting us up in terms of really understanding what we're talking about here today in terms of women-centered care. So I'm going to invite the next three speakers up, I guess, to speak about the Shauna Project as an example of women-centered care. And I think our first is Flo Ramble. Who wanted her own entrance, so here she is.
Just press the green one?
Just push
This one?
Yeah, that wants to go.
This one?
Yeah, that way.
Okay. No worries. Okay. Good morning, everybody. Whew. Been a busy weekend. And a change of weather. All right. So I declare no conflict of interest. And also, I'd like to say our work is placed on the unceded traditional and ancestral territories of the Musqueam, Squamish, and Tsleil-Waututh nations. So a little bit about the Shauna Project. So after 6 months of consultation with women living with HIV and also HIV service providers, Shauna was launched in April 2015. And among just before that time too, Shauna hired peer research associates to help with the recruitment of the study, and it's a 5-year longitudinal, Shauna stands for Sexual HIV Women's Longitudinal Needs Assessment. It's quite the acronym. And the peer research associates had a great time getting that down. So after we went, the peer researchers went to over 300 organizations in the first 2 years to do recruitment. I think our numbers today are around 326 women have participated. So part of this study, the women come in for a baseline, and they do a follow-up every 6 months after that. They are voluntarily tested for their viral load, CD4 count, STI testing, Hep C virus. Also, if there's any urgent infections that are happening at the moment, and regardless if they're in our study and stuff, they get on-site treatment immediately. Also, there's another component to our study which focuses on with the nurses. We have a nurses team too that do outreach also for the recruitment. And a participant sees a nurse first in an interview and then sees a peer interviewer or an experienced interviewer. And we also have a qualitative and an arts-based photo voice component of Shauna, where we've had 80 to 90 participants in those studies so far. I think, yeah, excuse me. And one thing I really love about Shauna, and where I've been there for over 3 years, is the JIPA and MIPA principles have been put in place since the beginning and throughout the whole study so far, and continues. So part of our PRAs, I wanted to share this in the middle circle. There's training in each of these cycles and circles, and it's a continuous learning experience for us in the PRAs. So like I said, they started with recruitment. We started doing information sessions too at different organizations. And then going over to the red one, we also created our Positive Women's Advisory Board. And that consists of about 12 to 15 women, and we meet quarterly, and we have for the last 3 years. And these women are coming from as far as Fraser Valley, like Chilliwack, Abbotsford, all the way to North Vancouver. And you know, it was a little a shy group in the very beginning, but to see these women after 3 years coming together every quarterly, and they just look like it's just a nice family that's come about. And I really love that Shauna and our whole team gets to bring all the information to them and ask their expertise and their questions, and let them know even what CAHR is, you know, because a lot of them are like, what's CAHR, you know? So we did a PowerPoint presentation for them to explain exactly where we bring all these findings, right? And all of them are part of our study too. And then going up to the purple one, that's where I mentioned the qualitative and the photo voice. And we were trained in qualitative research and the arts-based. We co-facilitated the arts-based research with another facilitator. And over to the pink one is our training with research and the findings and data, and letting the peers know exactly what knowledge translation exchange is and bringing that to them. And you know, like, I'm a visual learner, so I find it really important for the women that I work with too that they're also a visual learner. That's why you see a lot of little graphs and circles like this. It's very helpful, and it helps them to understand a lot more. And to see the numbers grow from when we only had 50 involved in our research project, and now we have, like, you know, 326. So. And down at the bottom is continued training, and also being co-authors, like on abstract papers. You know, rather than just having us read a paper and that and be a co-author and stuff, it needs to be explained and in a good way to the peers, and let them put their voices and their thoughts into that paper also. Like, there was an Indigenous paper done, and I got to put like visuals towards that paper. I got to put like a medicine wheel, I got to put like an eagle feather, or just an Indigenous woman's photo in there, which made it really a little more centered for myself to be able to put my name there as a co-author. And yeah, this is a photo. This is one of our recent photos of last December of our Positive Women's Advisory Board. And we actually take a photo each group quarterly, so we just have a nice memory of everybody, and you can see all those happy faces. But yeah, that's Shauna, and I think I'm going to pass it over now to Britt.
Hi, everyone. I'm Brittany Udall. I'm the Shauna Project Coordinator. Let me see. I'm just going to talk a bit more about sort of our approach to research and our model of ethical engagement with marginalized research participants. We have somewhat of an innovative approach to research in that we're really sort of active with our research participants. We're deeply community-based, so we involve community members at all aspects, from, you know, peer research associates, interviewers, data entry coordinators. As much as we possibly can, we like to engage with experiential people and have them on our team because we value their input. We also have a really large outreach component, which has proven to be really beneficial for both recruitment and retention. We are able to sort of literally meet people where they're at, whether that means going to their homes or going into a space where they feel comfortable in order to conduct the interview. From personal experience, I just find that we get sort of better quality interviews when we get to do interviews in people's personal spaces. It tends to help people relax and open up, especially when we're talking about really sensitive information, which is what we're getting at in our questionnaire. We talk about a lot of sort of traumatic experiences for people, and we put a lot of effort into making sure that we're not re-traumatizing our participants in the process. Part of that is sort of like a trauma-informed crisis response, in that if we're in a situation with a participant who is obviously in crisis or is having trouble with the interview process, we continually remind them that they don't have to answer anything that they don't want to. We're there to sort of make them feel comfortable, and we want to make sure that they leave our space and the encounter with us feeling like they've had an opportunity to talk about their experiences in a way that could possibly be meaningful and influence change. We also sort of are quite flexible with our participants, meaning that like if people miss their appointments or they come in and it's just a bad day, or they miss their appointments a lot, we'll still continue seeing them and we'll still put a lot of effort into letting them know that they're welcome to participate in the study, and we really value their experience, and we're hopeful that it will lead to sort of meaningful change within the community and healthcare systems. So as I said, a lot of it, what we do is relationship building. Since it is a longitudinal study, we get the opportunities to visit with people every 6 months, which over 5 years, which gives us the opportunity to see how sort of people's lives change over time, and how they're influenced by things like providing secure housing, or being connected to healthcare services that are appropriate for them, or how their lives are affected when they lose those services. As I mentioned earlier as well, we try and hire as much experiential staff as possible, which is really helpful in our interview process as well, because people just feel more comfortable when they're able to talk to people that they feel could empathize and understand the experience that they're going through. The whole process is really quite participant-led, in that we just put a lot of respect on participant boundaries, and we put a lot of effort into training our staff to make sure that they can respond to people when they're obviously feeling uncomfortable or feeling like they need to sort of talk or vent about whatever situation has come up in their life or that's coming up throughout the interview process. We also have we have a big harm reduction angle to our work, meaning that we provide harm reduction supplies to our participants if needed. So that includes condoms, lube, drug use supplies like crack pipes, meth pipes, clean needles, swabs, those sorts of things. As you can see, there's a photo of us in our van, which is jam-packed full of all of those things, plus candy and juice and clothes and some fun items just to cheer people up when they need it. I also just wanted to mention that a big part of our work is providing advocacy for our research participants and connecting them with healthcare services that they need, and in particular healthcare services that are appropriate for them. We do a lot of work to make sure that the agencies that we work with and refer people to are agencies that we trust, and we feel comfortable knowing that they're not going to re-traumatize our participants by engaging them with their healthcare services, and that it will be a positive and beneficial relationship with them. We go even further than that to make sure that when we're connecting with people, if needed, we will personally do that to engage those connections. So for instance, say if someone is looking for a healthcare provider for the first time and they're just reluctant to actually go out and meet them, we will facilitate that first interaction by accompanying them to that appointment and making sure that those first initial visits are positive. Our goal ultimately is to make sure that our participants are connected to good healthcare services and good housing services and good social supports. And there's just a huge amount of work that goes in on our end to make sure that those things happen. I think in general we sort of recognize that research has an important role in sort of connecting people to care. It could be very big in regards to sort of opening doorways to people to accessing care, as well as re-engaging them with care. And we do a lot of effort to make sure that happens. And we do a lot of effort to make sure that the research process can be really sort of meaningful and healing for our research participants as much as possible. And I will turn it over to Bridget, who will talk about our clinical stuff.
All right, hi everyone. I feel like I'm in an echo chamber a little bit, but my name is Bridget, and I'm an RN, and I'm the clinical assistant project coordinator at Shauna, and Aisha as well. So I just wanted to, not sure how I work this slide thing. Okay, got it. So I just wanted to say a couple words about the just some more specific stuff around our clinical engagement with project participants. So first off, we have who our clinical team is. We are mostly STI management certified practice RNs. We also have an LPN, and then our signing physician and Oak Tree Clinic site PI is Mary Kessler. So we every 6 months we do a sexual health screening and follow-up at each. So it's a longitudinal study, and we have follow-up visits every 6 months. So we'll do the sexual health screening, and We also, because we are all, the RNs are STI management certified, we are able to provide outreach-based treatment and partner follow-up whenever necessary. So partner follow-up and reporting for positive STI results is always participant-led and trauma-informed, and participant safety is always our first priority with this work that we do alongside people. We also collaborate closely with the BC CDC STI nurses and their ID physicians as well in this work. So another thing we're able to do, the RNs can do trauma-informed pelvic exam and PAP testing with study participants, and this is people who are not already connected to these services that we're doing the PAPs with. So in the case of abnormal PAP results, we do support participants throughout any necessary follow-up, so colposcopy, LEAP, and any other procedures, and I'll get into that a little bit more in the case studies coming up. And we do provide accompaniment to appointments if necessary ever. And I really want to underline when talking about our clinical work, with all of this, our goal is really participant engagement. It's not, and kind of filling gaps and reconnecting people. It's definitely not to duplicate services or to be acting as primary healthcare supports. But like Brittany was talking about, unfortunately, a number of our participants are quite disconnected from services, and we really prioritize connecting our participants to appropriate healthcare services that really work for them, and also in facilitating reconnection if they've been lost to follow-up, so if that service is something that will work for them. All right, so my next two slides are case studies. We thought it would be a good way to kind of wrap things up and show you guys how this actually works in practice instead of just talking a bunch at you. So this first case study is Melinda. She is, and I wanted to note, these are not, of course, this is not this person's real name, but it's also not the study alias that we use with her. So this is a totally made up anonymous identity. So Melinda was a 46-year-old cis woman living with HIV who is accessing cervical cancer screening or PAP testing with us only. So she was somewhat connected to a methadone doctor, but her main healthcare access was just walk-in clinics and the emergency department and just going into Emerge. So this was a woman that we worked with for many years, including we did advocate for her housing placement. And so she was accessing PAP testing with us and was diagnosed with cervical cancer, unfortunately, following an abnormal PAP. We accompanied her to all follow-up appointments, so her colposcopy and LEAP. She ended up undergoing total hysterectomy, and we then were able to, I think, kind of take that moment to refer her to a primary care provider who really worked for her. So she's being followed up by primary care now, and now she's in really good health, still participating in our study. She's still followed by that GP, and she actually works as an overdose prevention peer worker at the housing organization where we helped her get housed. So we thought this was a really positive example of some of the role that research can actually play in kind of filling gaps and reconnecting people with services who probably would not be accessing those otherwise. And I have just one more case study for you guys. So this is Jessica. And we wanted to talk a little bit about, so we have, Flo and Britt were mentioning, we have a sister study called Aisha, and that one is for women engaged in sex work who are not living with HIV. So this was an example of what would happen if we had a seroconversion within the Aisha cohort. So this is Jessica. She's a 33-year-old Indigenous cis woman and a street-based sex worker, and she first tested HIV positive at her Aisha follow-up visit. She'd been with Aisha for several years at that point, and of course she's now part of our Shauna cohort. So with Jessica, we got immediate referral and linkage to an HIV specialist for her initial counseling and care, and then we ended up connecting her to HIV care at a culturally specific healthcare service, and we did accompany her to the initial appointments as support people, and so she's also doing really well. Now she's stable on ARVs. We just saw her a few weeks ago. She's in good health, and she's actually looking into fertility planning. So that's another happy story for us to end on. So I'm just going to pass it back off to Britt, I believe, for our last slide.
Yeah, we would really just like to take an opportunity to have a moment of silence to acknowledge all the women in our study who have passed away. Thank you. Thank you. And we also just want to acknowledge all of our community partners and everyone that we work with, many of whom are in the room today. We couldn't do this work without you, and we really appreciate all of your input. Thank you.
Thank you so much to our wonderful, both of our study teams. Thank you so much for such a comprehensive, such comprehensive presentations. I think so where we're at now, okay, just to catch us up. So we started with presentations of here's some of the research that indicated that women were envisioning a model of women-centered HIV care. And here was the research that had gone into developing an example of what that model could include. And then we heard from our Shauna colleagues around, and here's how we put some of these principles into practice in our research study. So now it's my great pleasure to introduce Dr. Nero Pick and Dr. Deb Money, who are from the Oak Tree Clinic at BC Women's Hospital here in Vancouver, and who will share with us their a model, an active model of women-centered HIV care delivery that's been ongoing for 20 plus years. So we're so pleased to welcome you to share on the Oak Tree Clinic. Thanks, Deb.
Well, good morning, everyone, and thank you very much for getting up so early. I'm really honored to be here with all of these women who've been dedicated to supporting other women with living with HIV and working hard in research to improve the lives of women living with HIV. It's my privilege to speak in part on behalf of a very large Oak Tree Clinic team. Neora is actually the medical director, and she'll be speaking shortly, but I think I got asked to talk because I'm actually the oldest one. I've been around for the longest. I have no conflict of interest. So I just want to tell you a couple of tales, and the first one is a little bit of a walk back into history, and I want to try and set the stage, and many of you here are young enough that you don't remember this time, but in the late 80s, HIV was a very frightening situation. This was a disease that had appeared on the landscape, primarily thought to be a disease affecting gay men and individuals who'd received blood products. It was frightening. We didn't know initially even the cause. The HIV virus took a while to figure out that it was actually caused by a virus. And in the late 80s, we had no reasonable anti-retroviral therapies to offer. AZT was just appearing on the scene. At that point in time, Jack Forbes, the pediatrician, was beginning to see children infected with HIV at the Children's Hospital, and in fact, in 1988, took care of the first child born to a woman living with HIV that was known, at least at the time. At the same time, in a separate and distinct clinic, an adult ID clinic, David Burge was beginning to see a mixture of patients with HIV, and was starting to see women and recognizing that in fact that this was a non-discriminatory virus in many ways, and in fact it was under-recognized that women were being affected by this, and began to realize that the well-meaning clinics that were focused on primarily men who have sex with men and focusing on their needs, and the clinics were filled, rather sadly, with very ill individuals, that women's care was kind of being lost a little bit in this. And in discussion with women in the community, in a very participatory way, David and Jack actually brainstormed with them and said, wait a minute, these women, they're going to their ID care, they're going to their gynecologist, they're rushing their children to a pediatrician, and it's just too much, it's not working. How can we make this actually a women-centered, a family-centered process? And they said, look, actually, maybe we could bend, maybe we could be flexible as care providers and come to the same place and see the women and children in the same clinic. Hence, the concept of a women and children-centered clinic was born. A little bit coincidentally, I was finishing my residency and had the opportunity to go to Seattle for my fellowship. And again, let me set the stage. This is when we had no known effective treatments for HIV other than preliminary use of AZT, and 25% to 30+% of the women living with HIV were giving birth to children with HIV infection. And I had the opportunity to work at Northwest Family Center under Heather Watts, who now runs HIV care for the State Department for the United States. She had, her and a colleague, Lisa Frankel, had put together an obstetric and pediatric combined clinic where the women were being seen for prenatal care and the infants were being seen right in the same facility that was also had nursing, social work, and research integrated. And we were part of the of trials. And upstairs was an adult HIV clinic, so beginning to start to put the picture together. And then a moment in time that I'll never ever forget, which was the February long weekend, the President's Day long weekend in the United States, when the interim analysis of ACTG-076 was revealed to us. And it was where the first moment of the possibility of treatment as prevention was born, where we found out that if you were giving AZT to women living with HIV, that they had a substantive reduction in the transmission of HIV from them to their infant. Went from 25% to 8%, and that was an unbelievably transformative moment. So here we are. We've got these wonderful pictures. They look a little bit dated. That was David and Jack in the opening of the clinic in March of 1994. And then that year was the beginning of forming the sort of organic birth of this integrated service. I came back and we began to say, well, wait a minute, we've got adult HIV care, we've got pediatric care, but what about the sexual and reproductive health and the prenatal care for these women? Let's actually bring OBGYN into it. So we did that, and we managed to get nursing, dietitian support, pharmacy, social work, and began to provide the birth of holistic care. We were also, I brought back the database from Seattle, and we began to do ongoing surveillance, and in collaboration with David Patrick, we were the first province to offer universal testing in pregnancy. So this is, again, organically grown and developed such that we're trying to provide a virtual provincial service where not all women can come to our clinic in Vancouver, but we can try to, through connections with care providers in the community, try to provide sort of virtual holistic care with primary care now, with nurse practitioners, with preconception maternity care, pediatric care, gynecologic care. We have in-house colposcopy for that management of that complicated or that abnormal pap smear, access to termination as appropriate, and then the recognition that actually women were really struggling with mental health issues, and again able to attract psychiatrists who are willing to go outside of the box and work in an HIV clinic, and counselors, both mental health and addictions counseling, to try and address, at least in part, the needs of these women, and also recognizing again that our clinic is not in necessarily the most convenient location, so let's get outreach involved and let's go to the women where they are and bring them when needed. So a couple of other interesting initiatives. Mel Murray has been very involved in this WellTel, which is texting with women to engage them better in care. Using telehealth, we, as well, everybody in Canada has the same challenge. We're a geographically huge country. BC is a huge province. We've got a clinic sitting down in Vancouver, and that's not good enough. So we've been trying to use telehealth to outreach to individuals all around the province, and to ensure that as best as we can, women and families affected by HIV can try to receive care in their community closer to home. The other thing that was recognized, and I think Neora really was pivotal in this and other members of our team, is that Unfortunately, women living with HIV are disproportionately represented in correction services. And so our correction services are a little bit challenged sometimes in terms of healthcare provision. And so an outreach program was developed to our women's correctional service in Alouette out in the valley, and trying to provide in corrections comprehensive HIV care, which, you know, I'm putting this on one slide, but you might be able to appreciate the politics and logistics behind getting good health care into a corrections facility was not a trivial undertaking, and I'm really impressed with them for putting that together. So I'm going to ask Niora up to talk a bit about our next challenge that she's trying to address.
So along the many years that we care for women, we are always struck by the high prevalence of trauma of these women. And as you heard earlier this morning, over 80% of women living with HIV have experienced trauma. And there is increasing evidence that trauma actually affect risk health behavior, part of which is the main reason many women actually acquired HIV, and has impact on substance use and chronic diseases. As you can see from the pyramid at the right, adverse, especially if the trauma occurred in childhood or what's called adverse childhood experiences, or ACE, it actually affects cognitive impairment, social and emotional impairment, and increases the disease, disability, and even early death. And so we asked Chivos to look at over 1,000 patients and see what's the prevalence of ACE, not only adult trauma, but actually adverse childhood event for these women. And as you can see at the top, it's over 65%. So over 2/3 of the women actually experience adverse childhood experiences and trauma. And when we look at the impact of trauma, and specifically in HIV, it won't surprise you that there is increased HIV incidence, but also faster disease progression. Recent trauma actually causes decrease in adherence. Women who experience trauma are 4 times less likely to be adherent to their ARVs, and that causes more disease, more hospitalization, and actually twice the rate of death. So basically the main message of that trauma is that trauma is a key social determinant of health. We're really used to look at and to think about housing and food security, etc., as social determinants of health. We're not so much used to look at trauma as a social determinant of health, but it seemed to be a key social determinant of health, because this is actually many times the reason for the others. And as healthcare providers, actually between 1/2 and 2/3 of women experiencing severe violence disclose it first to their healthcare provider. So we need to be in a position to learn more about that, to know what to do with that, and actually address trauma. Also, in many cases, HIV itself is actually a cause for trauma. And so in case there's anybody in the room that doesn't know what trauma-aware care principles are, it's basically women who experience trauma and violence lost trust and lost their voice, choice, and control. So trauma-aware care is basically giving this basic human rights back to the women in the way we care for them. So care has to be safe, and we have to establish trust, we have to be transparent, and basically really acknowledge the Western system starts from a power imbalance. So we really need to acknowledge that, and basically acknowledge that the women are the ones who are expert on their health, and it's kind of our choice, our role to give them all the information so they can make the informed choices for their health, but they're the expert. And as Oak Tree has been trying to do for now 24 years, women are a whole person, so we have to do a holistic, culture-sensitive approach to care, and not to basically send them to get care, primary care in one place, mental health in another place, OB care in another place, etc., etc. And peer support has been really instrumental, and that's why we actually increased from 1 peer support to 4 peer support groups. And just what does it mean practically? A frequent scenario is a woman comes with abdominal pain, a 3rd time to the same clinic, and so current care usually means she's drug seeking, she's seeking attention, she has mental health, and basically redirect to primary care and basically dismissed. Versus a trauma-informed care means let's question the root cause of her pain, explore the safety history and history of the pain, acknowledge the pain as real, and basically discuss non-narcotic alternatives for her pain. Let her be heard. And it's really essential. You don't have to be a trauma specialist or a psychiatrist to provide trauma-aware care. Everybody basically needs to do trauma-informed care. And so Oak Tree has acknowledged the importance of trauma in the last few years, and we're by no means the expert, but we work with some experts like Colleen Varco from UBC to try to incorporate trauma-aware care into our daily practice. And this is just an example of a few initiatives that we have taken, some education. We work on making the environment safe. And we did an equity walk. I would encourage everybody to do in their clinic, regardless of where they are, to do an equity walk, which is basically walk with, we did it with an elder and indigenous patients to look how we can make the clinic a safer and more culturally appropriate, and it is an eye-opening, and basically give the women the voice and the choice and peer support. And specifically, that's trauma-aware care, and specifically to address the trauma, we added a female psychiatrist to our clinic and an addiction and mental health counselor. And so I will call Deb back to tell a few patient stories.
Jumping up and down here. We're trying to keep you interested with all the different people. So it's hard for me to believe, but it's actually been 24 years that Oak Tree has been in existence. I think we've had a lot of successes. I think we're constantly learning. We're constantly trying to improve. We've engaged over 5,500 women and partners from a multitude of backgrounds throughout British Columbia. We've seen many women who struggle with mental health issues, addictions, living in poverty, and trying to make them feel comfortable when they come to see us. And we feel that we've really been able to improve the quality of care and survival. In the course of seeing close to 600 pregnant women, if we calculate the prevention statistics, that's over 137 infants who do not have to live with HIV. The outreach workers have really made a huge difference in making our clinic more accessible. Peer support, despite the loss of Positive Women's Network, has really helped, and really trying to address social determinants of care has been critically important. And how does that kind of manifest? I mean, the reality is when women come to our clinic, we kind of have the usual clinical booking sheet with patients booked through the day. The reality is that they may be booked to see an obstetrician, they may be booked to see an adult HIV care provider, but when a woman comes in, we try to meet her where she's at, and it may be that particular day she's in housing crisis. So in fact, we redivert. She goes to the social worker, we try and deal with that, rather than putting the medical appointments up front, and we manage to sort of fit those in. We'd love to have it as a beautifully choreographed ballet. It's pretty much chaos most of the time, but we seem to manage to get people in and out. We've had a huge number of trainees that come to the clinic, and I think all of us would agree that when they arrive, having had often great background care in nursing, medicine, specialties, they come into our clinic and they go, oh, this is interdisciplinary care. As we walk around and the docs are talking to the pharmacists and the pharmacists are talking to the dietitians and the nurses are basically taking care of all of us, and it's a very, very interwoven flow. And I think one of the biggest things I think we've been able to provide is that real world experience for our healthcare professionals that have come through. We have very embedded research. We have well over 150 peer-reviewed publications. We continue to have a significant number of active, ongoing research projects, many of which has actually been presented here at CAHR, because we feel that it's our privilege to be able to see and take care of primarily women and children, and therefore we really need to try and move the dial in terms of new knowledge, and we've been constantly trying to do that as best as we can. And there is some data, we're always working to get better data. We've certainly been able to show that women living with HIV who are patients of ours are more likely to receive gynecologic care, more likely to be up to date with their pap smears. We've had fewer missed opportunities for vertical transmission prevention, and we're very proud of the ability of working with our women to have a really high rate of HIV virologic suppression compared to national averages. So I've found this CAHR meeting in particular a moment for me where I've been running into former patients from many years ago who I've seen through pregnancies, and I'm hearing about their teenage and nearly adult children, and it's been a very longitudinal journey with many of these women, and it's wonderful to connect with them, because some of them are no longer needing obstetrical care, but to hear how their lives have carried on. These women, these families have taught us resilience, courage, strength, and love. And the Oak Tree team has been phenomenal for 24 years. People have come and gone. We've had phenomenal, dedicated healthcare professionals, and we really want to thank everyone that's been part of that. A few years ago, in collaboration with our foundation, Neora and the team orchestrated a YouTube video that's really quite beautiful, and if you have a minute, I'd encourage you to watch it. And if you want to learn more about what we're doing, there's information on the website, and otherwise we're happy to answer questions. And there's some of the team.
I just thought quickly to tell a patient story, like a typical patient story, to make it kind of more real for you guys. So, for example, a quarter of our patients are immigrants, so a frequent scenario that we have in the clinic is a woman immigrates with her 2 children, and then she finds out in Canada that she's HIV positive. There's a lot of anxiety. Are the kids HIV positive as well? They are coming, and one of them is infected, and so she's devastated. She doesn't know the language, and now she has to deal with the HIV, and her child is HIV, etc. So we pulled the whole team together, and then she gets HIV care. The pediatrician are dealing with the HIV care. The pharmacists are dealing with all the medications. The social worker is dealing with her refugee status, housing, etc. And then she gets OB care and STI screening, etc. a little after. And the mental health team, the psychiatrist, the female psychiatrist, is pulled to address the trauma and mental health, etc. So we had a few scenarios where the women actually needed to run away. The children were left behind, and with a lot of work and advocacy, after a few years, we were able to actually bring the children together and unite them, etc. So this is a common scenario in our team, and we thought we'd share that with you. Thank you.
All right, thank you so much, and really such an amazing way to end on hearing 24 years of work from, so thank you, Deb and Yora, for that. It was really amazing to kind of end on that. I think we have about 5 minutes, maybe a little more, maybe 8 minutes, before the plenary speakers and people need to come in. So I want to open up for a little bit of discussion. I think it was really great. I mean, such an amazing group of speakers, and we want to open up and see if any questions for any or all. Go ahead. Do we have a microphone? Yeah. Okay, it's just coming. Yeah, it's good. Okay, it's all right.
Sherry's pretty loud.
We also have, sorry, there's a speak question up here. I don't know if we have another microphone for someone up here. Okay. Sherry, can you raise? Yeah. Oh, yeah, someone's walking over there. Closer. Thanks. Okay.
Hi, morning. Thank you for a great panel. Just a question about Oak Tree with the WellTel. In Ontario, we have the telehealth or the telenetwork system, it's like video conferencing. Oh, sorry. Hi.
Thanks. That's great if you can stand up. We can see you.
Can you maybe just speak a little more to the real value that the texting and the video conferencing, like what that mobile piece adds to patient care for those that wouldn't be able to come into the Oak Tree setting?
So I encourage you to talk with Dr. Melanie Murray. Melanie, raise your hand. And there's a few publications about that. I will just say one sentence. We tried it it has been shown to be effective in Kenya. We were actually the pilot for Canada. It works for some patients. It doesn't work for all, but it definitely increases engagement for some vulnerable population. And not necessarily the one we expected. We expected the youth to be totally on top of that, and actually it doesn't necessarily work with all the youth, but it does work with rural patients, some vulnerable population, and it is cost effective if people are wondering. So please talk with Dr. Mary more.
Can I just say one thing? I think WellTel, like the text messaging with patients, what that does is that sends out a message every week, just asking how they are. So it's not saying, are you taking your meds? It's ask them how they are, and it just gives them the agency to ask for what they want, what they need, when they need it, rather than waiting for an appointment.
Great. So I think the next, Sherry, do you have a microphone? Yeah, perfect.
Yeah, hi, good morning. Thank you. Hi, my name's Sherry, and I've been living with HIV for 25 years. So I've seen a lot of this, and I wish I lived in Vancouver and could go to Oak Tree Clinic and have the ideal, perfect model of care, because I've seen it evolve. I've known, well, Deb for a lot longer than you are, but, you know, I've been involved in this right from the start, and I guess what I want to put out there is sort of something for us to think about as a community of women living with HIV and a community of people doing research and care and with us. I really worry, you know, that we're doing so much research. The research is great. So now we have lots of answers. We have a beautiful model of care. What are we going to do as a community now to actually put this research into action? I have a phenomenal infectious diseases specialist who is well respected. I adore her. We have a long relationship. But her job is she's been very clear, is to treat HIV. And so I fall in that category of any of my trauma issues or other health issues are always back to primary care, back to primary care. So even though when I go for HIV care, which is probably, with most women, one of the most traumatic healthcare experiences they have, even after years and years and years, it's not really there. And what I see in other provinces is that it's getting narrower and narrower and narrower, and the physicians and other healthcare providers are having more and more to concentrate on their area of specialty, and we're getting away from that broader interdisciplinary care model. And I really worried that the research has taken the place of support and care for women. It is a way for women to connect, but it's not sustainable. So I wonder, when do we start to move now to really push for implementation of some of this stuff? Because I'm concerned about the women, that they're just going to kind of fall off when the research is done. Not so much in BC, but in other provinces for sure.
Okay, thanks, Sherry. Really great question. I know we only have a few minutes. I think both Dr. Mani and Wangari were going to briefly answer. We start here, and then if we can pass it on.
So thank you, Sherry, for raising a really, really important issue that we have so much research that we need to start translating into some form of action to help move issues forward. We've actually taken this model in Toronto as soon as it emerged, and we had discussions with the team. And the idea was always to ensure that we can actually take it and pilot it across different settings and see how it's going to work. For Toronto, we actually we're going to be pilot testing it, but we actually want to get funding to actually implement it. And we have actually mobilized aid service organizations, community health centers in Toronto, and have a proposal sitting with the Ministry of Health to establish a women-centered HIV care in Toronto that is outside of hospital settings. So we're thinking about what you're thinking. We're fighting. We just need to get the money to actually have it established.
Thanks so much, Margaret.
I'll be brief, I know, Kate. Sherry, I really think that your points are incredibly important. And don't get us wrong, the ability for us to do what we're doing in British Columbia is through a lot of struggles and efforts, and we're constantly having to defend the value of existing. And I think that this group and CAHR and all of us here really need to carry that responsibility for making sure that policymakers and health decision makers that are deciding on allocation of resources are aware that HIV disease has not disappeared, that it is still around, new diagnoses are still happening, it's a complex care issue, and if we put the money and effort into comprehensive care that it will prevent complications, it will keep people out of hospitals, it is actually the right thing to do, but it's fallen off the political agenda, and we really, really need to work hard to keep it there. And we also have to not be complacent in British Columbia, because we could have our funding whipped any time, and we've got to really keep advocating.
Thanks so much. I was just going to say, just wanted to add, I think that's a really great sort of way to end on, and I know we have people slowly trickling in. I guess just to say in terms of, I know from speaking on the Shauna end too, that we've you know, a lot of the programming support that we kind of provide off the side of our desks as part of research has just happened organically by gaps that exist, but you know, at a time where we're seeing, I mean, we all saw the Legal Network's, you know, summary of the huge gaps in HIV funding, PWN closing, you know, which is hugely, you know, hugely disappointing for so many in this community. So I think, I mean, we've been talking about shifting to try to get intervention and program funding, but I think there's a much bigger level, as Dr. Mani was saying, that we need to really be thinking about at a, you know, national level and provincial level. So I'm going to just turn to Angela to close.
So I guess I'll just close. You know, we have the next plenary coming in. So I'd just like to really thank our panel and also thank the questions coming from the audience. There's clearly an interest in this topic. So I think if everybody can just look around to see how many people came to an ancillary, a special session at CAHR at 7:45 in the morning, and to know that, you know, women living with HIV matter and their care matters, right? And so let's look around and say, there is actually, you know, and I think also for us to honor the people who have been doing this work. I mean, Sherry, many of the women in the audience who are here, many of the women on this stage, and honor the work that they've been doing for 25 plus years, right? And so this concept of women-centered HIV care is getting some momentum and finally getting some attention that it deserves. Dr. Mary Kessler has been an incredible, fierce advocate. Tireless in promoting why this is so important, but we have a community to make this happen, and I really want to just nail in on what Sherry has said, that this is a time of dwindling interest. It's a time of where we are talking about HIV as a, you know, it's a chronic, manageable, long-term condition, and maybe it doesn't need the attention that we think it deserves, and that's not true. We have momentum in this room, we have research, we have clinicians, we have community expertise, we have community leadership, and now we need to take it to the policymakers and the people that hold the money and tell them what's needed in Canada. So I want to thank all of you for being here today, and we look forward to continuing these discussions over the rest of CAHR. Have a great day.